Welcome everyone, Shaun Brewster, Bodine, Ledden here, having a chat today about the dangers, the associated risks with tunnel vision approach to clinical practice. Well, we've been chatting offline about, we get often a lot of questions from students and therapists that we've been to around the country, and they'll ask us questions like, my patient has sciatus pubis. How do I treat that? And that's kind of a problematic question because pathology is not the presentation. Pathology can take on many different forms. And so I thought we'd chat today about the holes in that philosophy and then maybe what people can do to fill those holes.
Yeah, that's right. There's so many things that can be involved. And when you look at if a patient comes in telling you their diagnosis of what they got, like where did they get it from, for one? What are their beliefs about it? That whole history that's involved. So we've got to understand that and almost sort of put what they think and I guess their diagnostic label off to the side for a minute and go through that structured assessment history, all of that process that you would do to come up with your own working diagnosis. Like a classic one is someone comes in and says, well, I've got sciatica, and then a clinician might say, how do I treat sciatica? What's the treatment for it? Well, understanding that to a deeper level, what really is sciatica? It's an umbrella of numerous different potential pathophysiological drivers. So we've really got to understand really what it is and the location of where those symptoms may be originating from before we can apply any treatment intervention.
Yeah, 100%. I think I've been saying this to therapists for years, especially in the early part of my career. I noticed that when people were struggling clinically, the things they didn't understand were how to jump from anatomy to physiology to pathophysiology. It's like, okay, somebody comes in with a problem with their hip or their foot or their shoulder. What are the things that could go wrong at a hip, foot, or a shoulder? How does it relate to the anatomy? What stage is the person at in that pathology? So is it an acute traumatic injury? Is it something that's come on slowly over time through repetitive load or whatever it might be? Because those two driving factors could completely change the way that you would approach a treatment plan for the person. So you've got to look at each region of the body and go, do I know all of my pathophysiology and pathologies for this region? To be able to say, yeah, okay, what's my differential diagnosis list? If it's a lower limb compartment issue, do I understand what a periostitis is? Do I understand an acute versus a chronic exertional compartment syndrome? Do I understand what a stress fracture or stress reaction is on a bone? Do I understand what a syndesmosis injury is? And this goes on and on and on. So when someone comes in and says, I've got shin splints, and the question is, how do I treat shin splints? Well, the answer to that is 10,000 different ways, because shin splints could be about 4 different things. And depending on the cause of that, we may change the treatment.
Yeah, and understand like what brought this on. Like, what have you been doing? Give me specifically what your current exercise regime is. What's the frequency of training, the intensity, the type of training, all of this sort of stuff. Has there been any changes? What other factors are going on? So there's numerous things that can be involved, and it's not just about doing something to that person. It's about what variables can we modify to potentially influence their overall recovery and progression through rehab. So there's so many different things. It's not like what we do as far as pressing on someone's tissue isn't necessarily going to recover or rehab them. That's one slice of the pie. That's something that we can do in amongst all of the other things that are going on. And we need to understand so many different variables so that we can really understand their story and educate them about potential contributors or potential causative factors as well.
Yeah, yeah. And so you talked about someone comes in with a diagnosis, and that in itself is a problem, because how much weight do you put on that diagnosis? I've had patients come in diagnosed by their physiotherapist, specialist, whatever, with a problem, and I've looked at it and seen something completely different and trusted myself in that, backed myself, and gone off to treat that thing and resolved it. So the initial diagnosis was wrong, or option B, which is maybe it coexisted with something else. And that's the thing. Like you could be diagnosed with a sciatica, whatever that is, because there's so many different things it could be. while they're coexisting with a hamstring strain. And so some of the pain that they're feeling down the back of their leg could be associated with tissue trauma, and some of it could be associated with neuropathy. And so there's, the diagnosis in itself is dangerous, necessary a lot of the time, but it's dangerous if you hang your hat on it and say, that's the thing, that's the only thing it could be.
Yeah, and let's talk about that for a minute, because that's a good one. When someone has, again, sciatica, and they go, all right, well, we treat the piriformis for sciatica because that's what I learned at school. And it's like, that's just so tunnel vision and more than likely quite inaccurate. But I mean, going through that process, well, first of all, we know primarily it's more than likely going to be lumbar spine related. And, we need to understand serious pathology that occurs in 1 to 2% of cases. So fractures, malignancies, tumor, space occupying lesions, things that could potentially cause sciatic related pain. Then there's specific diagnosis, so specific pathologies that can occur in 5 to 10% of cases, and then the rest of it is non-specific, where there's no pathoanatomical cause for their pain. There's various factors that can be involved, but we do need to know those specific causes of pain that are potentially quite serious, and understanding how to rule that out, not just looking at everyone as back pain or as sciatica, or sciatica is caused by piriformis syndrome, because again, looking at the literature, that's not the most correct terminology and the most correct way to look at it, because when you even look at sciatica as a diagnostic entity, it's sort of, well, you've got radicular pain, radiculopathy, you've got referred pain, and potentially peripheral neuropathy as well. So all of these things that could potentially be contributing to the same type of symptoms, but they could be treated very differently. And even then further looking at nociceptive pain, neuropathic pain, and nociplastic pain, and the various factors that can influence all of that. But that's why, like, if someone has a sciatica is a symptom, there is no specific treatment intervention for that until we sort of drill down on a little bit more. And we talk a little bit about treating a lot in the biopsychosocial model, and steering away from a pathoanatomical model or a biomedical model. Well, you need to know a bit of both. And even when we look at a biomedical diagnosis, I think that can certainly be important, but it doesn't mean that biomedical diagnosis needs to be I guess your education shouldn't be embedded in that biomedical diagnosis. I mean, that's a component of it, but what are the other contributors and psychological factors, social factors that fit into that model that are influenced by that? So they do go hand in hand. We can't be just in one or the other. So we've got to be in a little bit of both.
Yeah, I think another, building on sort of what you've just said about that, biopsychosocial model versus the biomedical model, and the longer somebody has pain, or let's say call it pathology or fit clinical presentation, the more layers kind of get stacked on top of that. And so somebody might sprain their ankle today. Today, they have ligament damage and some inflammatory processes taking place. So some swelling, some redness, some heat, some pain, dysfunction. And you can address those symptoms and you can rapidly decrease their discomfort. And then if you do all the right things, tomorrow they get better, and the day after they get better and better and better and better. And then within a week or two, they're kind of back to normal. But if they're not managed well, that ankle sprain becomes something entirely different. It's like a tree, like if you slice a tree in half, you see the rings. So if the ankle sprain was the middle ring, the older that tree gets, the longer the person has the problem, the more rings, the more layers, the more wood you've got to cut through to actually get down to the source of the problem. And so that what was an ankle sprain today, in 6 months' time, becomes central sensitization issue, or it becomes a peripheral neuropathy because of the inflammation on a nerve that was supplying that tissue. And so no longer are they dealing with the ligament anymore. You're dealing with chronic central and peripheral neurological changes, which are in a completely different situation. So the patient comes in and says, I sprained my ankle 6 months ago. And you treat that, and you Google ankle sprains to treat ankle sprains, you'll have things like rest, ice, compress, elevate, which is mostly outdated now, but those sort of things are the things you come across to treat an ankle sprain. If it's 6 months old, it's no longer an ankle sprain. It's entirely something else. And so that's why we've got to understand the physiology, progression, pathology over time. Like, how does it actually start? How does it progress in the early stages, the middle stages, the latter stages? And then what are all those layers that come in over the top? What are the psychosocial components to it? What are the physical, like the biomedical, not biomedical, what are the physical adaptations to the pathology? How would the person develop their antalgic gait? What flow-on effects up and down the chain might they have as a result of that? So, this can be really disheartening, this conversation, for someone listening to this going, well, I thought I knew how to treat ankle sprains, or I knew how to treat sciatica. We're not saying you're wrong. We're saying, let's look a little broader, try not to be too narrow, and then consider all of the different factors that might be playing into this, because a treatment plan should involve clinical reasoning, not just understanding where their pain is.
Yeah, and I had an interesting experience with my barber yesterday, and he's a bit of a catastrophizer. So it was interesting though. He's had groin pain for quite a while now. He plays soccer, and he's telling me that it's pubalgia and everything that's going on about it and what it is. And I was talking to him and end up finding out, well, how did you come across that diagnosis and what are these factors that may be contributing to it? And he's like, oh, I self-diagnosed it. I found it on Google. So I've been icing and I've been taking anti-inflammatories before I run. And I'm sort of like, well, hang on a second. What is that telling you if you need to do that before you can go and exercise? He's like, I've got 12 out of 10 pain. And when someone's saying that sort of stuff, that should automatically set off sensors that this is a lot more than physical pain. There's psychological influences. And I said, well, like, what are you doing about your load management? He's like, oh, I go 100% all the time. I need to play every weekend. If I don't have soccer in my life, I can't go on. So although he had this self-diagnosed adductor-related groin pain, or as there's an umbrella of different terms that can go within that, but you could see that the real significant contributor to that was how important soccer was to him and how important exercising and doing all of that sort of stuff, how that sort of is potentially amplifying his pain experience. Not knowing how to manage his load and all of that sort of stuff, not doing any strength work and just expecting it to get better. And he's asking me, how long is it going to take? I said, look, I don't know. We've got to understand, we've got to have a look at various factors and contributors and the level of irritability and the sensitivity, your mechanisms, like how all of these other factors that are going on with it. And, asking like, what exercises should I do? Well, it depends on where you're at and what your current capacity is. So I guess my point here is that I can't just give specific advice without really going through that detail and really understanding where that person is at that particular point in time, strength-wise, physically, all of that sort of stuff, but also psychologically and socially. Like there's a huge interaction with social factors. When you look at not being able to play sport, not being able to have that outlet with friends and having family come and watch, all that sort of stuff. So I mean, if I had have given him very specific advice of what you need to do for pubalgia or for adductor-related groin pain, well, that's sort of I guess probably not very accurate. It'd be like if a doctor prescribed a medication without knowing the history or without knowing exactly what that condition is and the contributors and any other medications that you might be on and other diagnosis or other illnesses that you have, because that then wouldn't be a very effective intervention.
Yeah, and you'd be liable.
Yeah.
That's I think it's dangerous from legal and ethical perspective to not understand the pathology, or at least at the very least how it's presenting for the patient completely, and then to prescribe a treatment. Obviously, medicines, medication, pharmacology is higher risks, but even manual therapy treatment can potentially be dangerous. If you've got someone with sciatic nerve irritation at the ischium, the lateral surface of the ischium where it interfaces there, and someone's diagnosed it as a piriformis syndrome because we've got a type piriformis, and they're diving into their gluteal region with an elbow, compressing, irritating an already mechanically irritated nerve. It's just only going to get worse. Only going to get worse.
It's funny, isn't it? Because you go in there, and it hurts, so it must be good. Well, yeah, the nerve irritated and it's sensitized, so it's going to hurt.
Have you ever been mad and someone keeps telling you something they believe to be true and you know they're wrong? It's exactly the same thing you're doing to that nerve.
Yeah.
So we talk about things like, this is something that popped up as you were chatting about, we talk about things like adductor-related groin pain, pubalgia, anterior knee pain. These are all very general terminology. Like our diagnostic terminology over the last 2 or 3 decades has gone super generic, away from very specific diagnostics. Things like anterior knee pain, which we used to call patellofemoral pain syndrome. Prior to that, it was even more specific and more specific and more specific, describing certain changes in the articular surface on the posterior part of a patella. And it's become more and more generic. And look, pubalgia is a great example. What does pubalgia mean? Pain of the pubic area. It doesn't really tell you what's going on. And so when somebody gets a diagnosis like, I have pubalgia, how do I treat that? You can't answer that question until you understand all the potential contributing factors to that problem. And then only then, which one of those, which collection of symptoms does the patient present with? Well, those are the things we need to address. It's not a condition we're addressing, it's a person. It's much more complex.
I get this all the time. Like, oh, no, but it was osteitis pubis. And then, so is interesting consensus as about, I think it was medical professionals from all over the world. They came up with about 18 different diagnostic entities or diagnostic labels that all meant the same thing. So now we look at adductor-related groin pain, pubic-related groin pain, inguinal-related groin pain, and iliopsoas-related groin pain, because you could call it, let's say, osteitis pubis. I could call it athletic pubalgia. And at the end of the day, we're probably talking about the same sort of thing. And how do you differentiate between the two? Well, it's difficult and maybe impossible as well. So the thing is, with different diagnostic labels as well, it can add to increased confusion to the patient and potentially influence different management approaches. You look at, so the terminology of tendinitis versus tendinopathy, well, potentially that could influence a rest approach versus an active approach. And when we look at the evidence around management of tendinopathy, typically, well, it's load management really, but then loading it up again rather than injections, icing, and resting. So that's why, like, to know that sort of stuff, we do need to understand the biomedical model. But as I said before, we shouldn't embed everything as far as our education advice in that model. It's just because if we just focus purely on the biomechanics and biomedical focus, we're missing the huge influence of, and the complexity of a pain experience. It's there's a lot to it.
Yeah, and this is the danger, right? And so we, in our courses, where we often talk about all of that, the soft understanding rather than the hard knowledge. So hard knowledge, if we look at that as the biomedical understanding of the body and how things work and don't work when they're broken or torn or damaged in whatever way. And then the soft approaches being the psychosocial components of that, the influence of beliefs, fear, apprehension, mood-related disorders, all of that other stuff. And those two things often are viewed as two separate things. But I kind of look at it like the biomedical concept of an understanding of the human body is the foundation. Without that, you can't then make sense of the other stuff. So if you only took a therapist and trained them how to communicate effectively with patients and understand the importance of psychology and all those other things I just mentioned, if you just did that and you gave them patellofemoral pain syndrome, You can't talk somebody out of having knee pain. And even if you address their related disorders, the stress of work, and you still have to understand what are the mechanical forces at play on this knee. What are they doing at work, at home, in their sport, contributing to those things? And then what makes that a chronic pain presentation? That's all the other stuff. That's the soft stuff. So you can't separate the two, nor can you have one without the other. So this is a really important thing. And it, like I said before, we don't want our audience here to be disheartened and say, well, I don't know all that stuff. So therefore, am I negligent with my patients to say that I can treat them when I don't really understand it all? No, you can still help them. But the important thing is not to make claims about I know how to treat this problem until you gather enough data to really know what it is. Like, okay, it's not just this. There's other factors, and how do I address those factors? And if I can't, what do? We handball. There's other therapists to help you with that process.
Yeah, and even like just I guess having a superficial view of it as well, that's in a biomedical model. Like if someone has back pain and and the therapist is saying, oh, it's their QL. Like, yeah, their QL might be sort of press on, but how many different layers of tissue you're going through to get there? By jamming your thumbs into the side of their body, well, also anterior to that is the lumbar plexus, so it could be potentially sensitive as well. So when you look at the complexity of pain, it's so hard just to even say, well, it's that muscle that's causing it, or classic ones, oh, it's your levator scap that's causing your pain, or your upper traps. Well, I mean, muscles can be sensitive, but that doesn't necessarily mean that it's the cause of the pain. There's so many different things or like, a lot of musculoskeletal pathologies, a lot of serious pathologies can masquerade as musculoskeletal pathologies and potentially be overlooked and missed. So that's the real importance of that thorough history, physical examination, but also understanding pathology to a little bit deeper level as well.
Yeah, and that kind of what makes our work so exciting as as a health practitioner. There's always something new to learn, and as good as you think you can, there's always more, right? If someone came to me with a hip and pelvic related issue, and I looked at that and it wasn't immediately clear what was going on, I would refer to Bo, because Bo, that's your special area of interest, right? Likewise, if you had someone come in with a lower limb problem, you'd go, I could probably have a reasonable assessment of what's going on here, but it's not better to pass it on to Shaun, because Shaun knows that stuff really. And everybody has their own area of interest, and you might have multiple areas. Fantastic. No one's the best at everything. And so if you don't feel 100% skilled, you've got two options. You refer every time, or you work on that. I think that's what we all need to do, is just continue to work on and go, where are the holes in my understanding of pathophysiology in this particular region? And not only that, but like, do I know the anatomy really well? That's your foundation, anatomy. Then how does the anatomy relate to one another? There's your physiology. And then what happens when that gets injured or damaged? Well, that's your pathology. And then what happens when they've got a pathology, and how does that track over time? Well, that's pathophysiology. And there's just layers and layers of science. Stuff that we all know. I think everyone instinctively knows this, and they know where their gaps are. But it's pretty easy to hide from it and make these narrow tunnel vision diagnostics and sort of say, oh, you've got shoulder pain, it's likely to be a bursitis. I've seen that before, and that's, bursitis is not a diagnosis. It's a symptom of something else happening at the shoulder. And so you don't treat the bursitis and you resolve a symptom. All still there.
Yeah, and so often their beliefs are really embedded in that. This bursitis has been playing up for years. Well, but what are the other factors? Like, what have you noticed any changes in your lifetime or your stress levels when those symptoms do tend to exacerbate, or amounts of load or whatever? I think, as I said, we do need to understand pathophys and biomechanics and that biomedical lens, but we also primarily need to look at the person. Once we can rule out things that a little bit more sinister and your red flags, and identify your yellow flags as well, like really looking at the person and how this is affecting their life, looking at their beliefs around pain and how they see their future and their I guess their what's the right word, um, when someone is a little bit more positive or optimistic, understanding what their outlook is and how they see their recovery rather than, dwelling on things and focusing more on the pain, because that can be an indicator of poorer outcomes.
So, and that's that short versus long-term view of pathology. Is it a short-term thing? Well, you could probably get away with it. More of a biomedical lens in the short term. Know that you're dealing with a human as well. And so if you give the human time to think about it, they will create a story around their presentation that's inherently accurate.
Yeah.
And so we've got a responsibility to give them that very clear understanding of what it is actually going on and what the potential positive upside of that is if they do the right things. And so that they don't then create a new story around that and then develop a chronic pain presentation, which is invariably completely different to the initial pathology. It's something much more complex.
Yeah, I see a lot of hip and back pain presentations, particularly chronic ones as well. And someone say, "Oh, well, I've got an L4-5 disc bulge. I've got it. That's like it's mine. No, you're not taking this away from me." And and it could be years on, and that's why I can't deadlift, or that's why I don't round my back or anything like that. So you can see how, although that initial injury, why is that so strongly influenced their beliefs? Because that was probably a really horrible time. It was really quite distressing. That affected their life significantly. They're really worried that could potentially come back, or certain movements may exacerbate that. And these are often quite negative beliefs. So understanding that what a disc bulge is, and when we look at a prolapse and all sorts of different changes that can occur at a disc, I think that's important because that is a specific pathology, particularly in acute pain settings. But that we know when we understand the pathology and the prognostic factors around that a lot of the time, in fact, most of the time, that can completely resolve. And in fact, the worse that the disc bulge is, if it's a disc sequestration, that can completely resorb and recover better than more minor disc injuries. So knowing that, at the time that was a specific pathology, but 5 years down the track, it's really non-specific low back pain because so many other factors have been involved and influenced their thoughts, their beliefs, their behaviors, their understanding, the way that they move, all of that sort of stuff. So I really think that, we do need to have a little bit of both. And that way we can de-threaten the way that they move and try to help remove some of these unhelpful beliefs and change some of these narratives around recovery and movement.
Yeah, 100% agree with all of that. So that, coming back to the initial concept that we started with today, because it's so easy to go down rabbit holes and all of this stuff. We could go for hours and hours.
What even was the topic?
What was the topic again? We can't hang our hats on a diagnosis. Not only is it potentially the wrong diagnosis, so you've been self-diagnosed, like your barber, the other clinician who diagnosed them got it wrong or missed something. Yeah. Or maybe they come in and you perform a diagnostic procedure or an assessment procedure and come up with a diagnosis. You could also be getting it wrong. So let's absolutely understand pathology and understand different conclusions that patient can have. Keep in the back of your mind that there's going to be more rings to that tree trunk. There are almost always other factors, especially when they've had it for longer periods of time. And so then we start to take actions to reduce the things that will create more rings on the tree. First of all, we've got to stop that getting worse. Reduce their pain, reduce their behaviors that are negative towards their outlook that is negative towards their clinical presentation. And then start moving them away from pain, letting them focus on the pathology, because the diagnosis is often the problem. It's like an X-ray. That person that had the disc bulge, it's an X-ray, and they see some kind of structural anomaly inside their back, and they go, well, that's what I've got. We know that an X-ray or an MRI or any kind of imaging is a snapshot in time, a moment in time from a specific angle On that particular day when the person may have been sensitized more or irritated more, or there's more inflammation, whereas later that day even, it could have been a completely different image. And so time changes things, the body heals. Our job is to identify where they are on that particular day, as many factors that contribute to that as possible, and help them move in the right direction.
Yeah. And I love that explanation as well, that specific snapshot in time. It's sort of a bit like a garden, right? You might have pruned something at a certain time, but it grows, it changes, and depending on the environment that it's in, whether it's in good healthy soil and it's being watered regularly, and there's good conditions and all of that sort of thing, that can influence recovery. So it's the same with a person, depending on the environment, the influences, their social support network, their work related life, all of that sort of stuff, the level of activity and exercise and nutrition, all of those factors influence pain, not just specific pathology. Because even if that image, like you look at tendinopathy, we know that the tendon structure doesn't necessarily need to change for us to see a change in symptoms, but other things certainly can change and can influence it, and that's the world that we live in, and us as very adaptable creatures. So yeah, we've got to look at the person just as much as we do need to understand the pathology.
Yeah, and keeping in mind that, you can have a tendinopathy and you can not alter the tendon, they can still get better, perform better, have their strength back, have no pain. But if someone damages a tendon by getting ran into the back of their tendon with a shopping trolley, well, then we have to look at the tendon. We have to look at that structure because there's trauma to the tissue. Does that require surgery? Does that require unloading? Does that require splinting? Does that, whatever the problem might be. So like I said before, you can't take one away from the other. And your garden analogy is a really good one. We've had garden analogies today. We've had tree analogies today. I feel like we've got a whole other theme for a topic for another discussion. So we might wrap it up here, but before we start talking about shrubs and flowers and different other types of. All right. Thanks everyone for listening and tuning in to our ramblings. We'll talk to you again on the next episode.
Cheers.